Good morning and welcome to the California Collaborative's monthly webinar. We are so glad to have you with us. Today's agenda will focus on 3 of the Collaborative's policy priorities. We have 2 Collaborative / Master Plan for Aging LTSS subcommittee members who will engage us in discussion around the proposed long-term care at home benefit. We're also going to be joined by Christina Bass Hamilton, who is going to provide an update on the long-term care financing efforts being spearheaded by our colleagues at CADA. And Athena Chapman of Chapman Consulting will discuss the idea of creating a statewide health and LTSS advisory council. We did save ample room for discussion, so please feel free to submit your questions via the Q&A feature or raise your hand to be unmuted during Q&A. Before we dive in, we are delighted and honored to have Assemblymember Nazarian with us to provide some welcoming remarks. So Assemblymember, go ahead and take it away when you're ready.
Thank you so much. Good morning to everyone. Wanted to just take an opportunity and say how happy I am and proud I am to be a partner with all of you. Thank you for everything that you've done. This last budget was extremely difficult, but unfortunately I feel that the future budget is going to be even more difficult. So thank you for hanging in there. Thank you for the united voice that you came to meet this challenge. And my message to you this morning was basically one of 2 things. A, I haven't been around long enough in the aging community to really understand how united you were this time, but from everything I'm seeing and hearing and being told from advocates, this was one of the best scenarios where the entire community came together and worked very hard, diligently, stayed on message, and we were able to deliver and protect ourselves from cuts that some other places weren't so fortunate enough. But now this interim period of the budget is one thing. As revenues keep on falling and the challenges are going to become borne upon us again as a legislature to look at where we can make certain cuts and make programs continue at much leaner, it's going to be important for you to be honing in on exactly how we're going to work together again and refine the messages and spend the next few months getting prepared so that as the new year begins next year, even though we still are going back after the summer recess, hopefully we're going back, and there's not going to be any more delays. But for the purposes of the budget, that we spend the next few months looking at how we want to strengthen our message and look at the service delivery system in light of our budget challenges. So with that, I appreciate everything you've done. I've been a proud partner. Thank you for standing shoulder to shoulder with me, and look forward to our continued work together.
Thank you so much, Assemblymember. You're welcome to hang out with us, or if you've got to go, that's okay too. And at this time, I think I'm going to pass it over to Marty and Susan.
Thank you.
Hey, Susan.
All right. Good morning, everybody. So we're going to try to give you an update, and we obviously won't. We just saw the latest draft as well as a excellent chart that the department produced about 15 minutes ago. So Marty and I aren't quick enough to turn all that around for you. So what we will share is what we knew as of last night around the new long-term care at home benefit. And can I advance the slides myself? Oh, there we go. All right, we're ready for the next one. So many of you know that the department decided to name the Master Plan for Aging LTSS subcommittee members as the official stakeholder group to advise on the long-term care at home benefit. Here's a list of that group, and we have been augmented by about 15 additional members who will be joining for today's second stakeholder meeting. And next slide. And from our perspective, we wanted to, something that may have been lost in the shuffle is in May of this year, the Master Plan LTSS Subcommittee issued its final report, and that was submitted to the Secretary and the Governor this summer. And the key components of that report are listed here, the 5 main areas, and then there is a 6th area that is gubernatorial or cabinet level leadership is also included as a sixth domain. So we wanted to start the conversation about the long-term care at home benefit, revisiting these key components of the ideal LTSS system. We want to make sure all of these attributes are present in anything going forward. Next slide. And in particular, objective number 2, which is access to LTSS in every community. We now feel, because we have the Master Plan for Aging process well underway, we have the report submitted to the Governor and the Secretary, that this should be the guardrail and the guiding light for our work going forward. So we think that the long-term care at home benefit fits squarely in objective number 2, access to LTS in every community. Next slide. There we go. So what we know about the LTC at home benefit, and this is familiar to many of you, is it grew out of COVID-19. First, looking at the overall impact on the entire state of California, all of us, and as the Assembly member said, the impact on the economy and the budget. It also looked initially when hospitals were at or beyond capacity, and individuals needed to be discharged into nursing homes, and then nursing homes became hotspots. So it was really intended to be how we can decompress nursing homes in the COVID-19 environment. And then, of course, not soon after COVID struck, we started to feel the budget impacts, and we all know very well the hit to our budget in the May revise and ongoing, as we just heard, continued declining revenues. So growing out of a budget crisis is really, and a nursing home crisis, was the impetus for this benefit proposal. Next slide. So the data we have to share today, as of yesterday, 8,200 Californians are hospitalized, 2,000 in ICU beds. So we know that those individuals, many of them will need to be discharged to nursing facilities. As of yesterday, 16,000 nursing facility residents had reported positive for COVID. And that's with the data that requires only 10 or more to report. We know that 40% of all fatalities in our state have occurred in nursing homes, and all deaths in California, a shocking 75%, have been individuals age 65 or older, while that represents just 15% of our state's population. And we are not fortunate, none of this is fortunate, but our state does track closely age and ethnicity. We're one of the only states that does that. And consequently, we know that 68% of all deaths in our state have been people of color. Next slide. Take it away, Marty.
Okay, yeah, we're going to go back and forth, and Susan certainly comment as we go. So Susan, let me do this one because I like this Center for Medicare and Medicaid Services slide that they put out a few weeks ago for the first few months of the pandemic. And what's interesting to me is that it really emphasized, if you look at the yellow bars, yellow versus blue, that yellow bars are dual Medicare and Medicaid eligible folks, which means by definition they're low income, older and long-term disabled folks. So if you look at the size of those bars, you clearly see the impact on the low income elder population and disabled population. And then if you go down below, you see the racial breakdown, and of course the age breakdown getting higher. And the racial breakdown is on the CMS national data is entirely consistent with what we know here, This is hospitalizations. They didn't release deaths, but hospitalizations is clearly show that if you look at the Black population, the Latinx population, et cetera, that you're seeing significant disparities. So we know it. It just points to the issue of dual eligibles or Medicare, Medicaid eligibles being one of the super high need groups for this discussion that we're having about long-term care at home. Okay, next slide, please. Let's do timeline a little bit, but I wanted to back up to one of Susan's comments and talk about how we got here. There's no question that the advocate community was a little cynical when this benefit proposal was released right at the same time as the efforts to eliminate adult day health care and MSSP were happening. Nonetheless, I think we all, many of us, not all of us, also saw it as an opportunity to think about a much broader long-term care or LTSS type of benefit in the state of California. And in a minute, we'll talk about waivers versus state plans. But it also was an opportunity, and now that the legislature has done, the smart and the wise thing and continued ADHD and CBAS and MSSP, now maybe we can concentrate a little bit more on the nursing home decompression side and the expanding LTSS benefits across the state side of this discussion. So that's good. Rough timeline, a very fast timeline. Essentially, the state put this out. I was just looking this morning, May 22nd, they put out the first release announcing the benefit. They're in a process of going through 3 stakeholder meetings, of which the second one is this afternoon. And the last one, right now, the last one, we may call for additional stakeholder process, but right now the last one is scheduled for right at the end of July, with the idea that the state would move on to continually improve the draft and post a draft for a state plan amendment for public comment, and then move to get formal approval from CMS and to go live with a benefit in 2021. When they first put it out, they said, I believe they said January 2021, which of course is very, very, very optimistic, and I don't think possible even. But 2021 itself is also optimistic, given that various things have to be done. So I mentioned the stakeholder engagement process. First, the state asked the LTSS subcommittee of the Master Plan on Aging to serve that role, and Susan mentioned the group before. This DHCS then added some stakeholders that are going to join the stakeholder meeting today. I think there's a question of what is the legislative role. I think Sarah Steenhausen coordinated a legislative briefing for staff on the issue. I believe the DHCS thinks that it's okay, that it doesn't necessarily need legislative authority to do this. I'm not going to comment one way or the other, just that's my understanding of the discussion so far. And of course, our ability to get ready and change quickly to offer such a benefit through the system of service delivery is a challenge. And how we're going to evaluate this thing, obviously, we need to think about as well. Next slide, please. Great. Let's just mention that the state is planning to use a 1915I state plan amendment. I am not good, and maybe Susan will help me, on defining exactly what a 1915I is, but the state plan amendment versus a waiver is important in itself. And as I see it, it's important because the state plan amendment essentially says that a benefit will be offered to people throughout the state, and anybody who needs the benefit will have an entitlement to it, versus the traditional home and community-based service waiver programs allow the state to limit numbers, limit expenditures, have certain defined, more tightly defined criteria. So by definition, waivered services are more limited than state plan amendment services. So I myself, I'll be honest, I saw it as a benefit and advantage that the state was proposing to do this as a state plan amendment. We'll say a little bit more about licensure category, but in a trailer bill language that the state proposed, which is still pending, they did propose a new licensing category. Some of us on the advocacy side are not sure that new licensure is necessary, and we can come back and say a little bit more about that. Next slide, please. So we mentioned the decompress purpose and the avoid institutional placement purpose. There's clear language about looking for people in transition, so and trying to serve them. So people who might be going into a nursing home, might be coming out of a hospital and either going home or going to a nursing home, or people who might avoid nursing home use altogether. I think the decompression was what the state on May 22nd basically said, this is the reason we're doing this. We've had such tragic results in nursing homes. They may not have used the word tragic, but I would certainly, and I bet Susan would. We've had such bad results in nursing homes. We need to avoid more people going into nursing homes and have ability for people to get out of nursing homes and get more appropriate care. But as time has gone on, they've added language that essentially suggests that LTSS services for a broader population with the overall goal of avoiding institutionalization are also on the table. So that concept has moved, and maybe it's moved again in the draft that came out today that we haven't had time to read yet. Okay, let's go to the next slide. I think the target population, they've put in their initial language information about people who need nursing home care, either acutely or for short-term stay, that sort of thing. But again, I think if this is going to be an LTSS benefit for people in the state, yes, we're interested in the broader population. Also in this target population area has come up the question, is this a duals benefit for Medicare, Medi-Cal folks, or is it Medi-Cal only, or both? And essentially, I did read in today's paper this morning that they start talking about duals and saying, yes, they're going to try to make this a benefit that can be eligible for duals. I feel like that's an important issue because of the kind of disparities that we saw on that yellow slide earlier for the duals population, the fact that so many older low-income Californians are dual eligible. So we want a benefit that's going to reach them as well. Let's see here. Let's go to the next. Susan, I can't remember. Yeah, let's go to the next thing. So this is what we were talking about a second ago. So I'm not going to say a whole lot more about that. So let's keep going. Let's say one more. Okay. So clearly we're talking about an assessment process. I think it's unclear yet how that interacts with things like in-home supportive service assessments, assessments that the health plans may do. The language today seems to indicate a desire to coordinate those assessment processes. We mentioned the transition services to help people to get successfully from hospital to home setting without necessarily going into nursing homes. Clearly, there's a care coordination function. And let me just say that from the beginning, when the state first introduced this to the Master Plan on Aging Stakeholder Committee, it talked about, quote unquote, a hospice-like benefit without the end-of-life component. Now, they've backed off that a little bit, but I think, what that says to you is they're thinking about a benefit that tries to coordinate all the different types of services that a person might need with nursing home level type of acuity, both LTSS needs and medical needs. So home and community-based services, of course, to be included as well. And then that service mix would include medical as well and skilled as well as personal care and other LTSS type of services. But exactly how that, some of our questions have to do with exactly how that might happen and such. So on this rates issue and cost issue, I'll just say that what's gotten the most attention is language that this needs to be a cost neutral benefit. In other words, that the state not spend more on it than it's spending already. It's hard for us to think about how they might offer a deeper, more available LTSS services to folks in the state without it costing a little bit more. One could imagine some nursing home savings, certainly, for people who were going to go into nursing homes. But you could also imagine that some of the savings might be on the acute medical side as people's conditions are managed and chronic care is managed better. But of course, those savings are Medicare savings that accrue to the federal government, and the state and the feds often have a difficult time negotiating over how any savings are shared or if savings are shared. So the cost neutrality provision is tough. I think the other point that I would just make here is they say this has to be available to both the fee-for-service Medi-Cal population and the managed care Medi-Cal population. And as we know, the state pushes most of the Medicaid or Medi-Cal program through managed care plans in the state. So some of the details on that are yet to be worked out, how that might work as well. Next slide. So what they said about provider requirements is that they called out as eligible for this new license or not needing it really, licensed home health agencies and hospice agencies. Now that's fine. And at the same time, we know that we have adult day health care centers, we have MSSP programs, we have independent living centers, we have, in my case, community clinics, we have PACE programs, all of whom may want to provide such a benefit if it were available. So far, the state is silent on this. A number of those entities are already licensed or certified in some way, which has raised the question of whether a new licensing requirement, a fairly expensive licensing requirement, and new interaction with the Department of Public Health on licensing is absolutely necessary to get this benefit out and on the street. And then the care coordination, we already said this, the requirement to arrange and coordinate all services, including medical, LTSS, et cetera, IHSS, et cetera. Next slide, please. Okay, let's go back to Susan. This is kind of the sum up slide. Susan, take it away.
Yeah, so I wanted, I meant to start out, thanks Marty, by commending the collaborative for the letter that was submitted. It was excellent, and things are moving so quickly. So to be on the record, I think for all of us, we'll have to keep submitting letters as things evolve. So even today, we're getting new information and the areas, and I can tell you that the LTSS subcommittee of the master plan has a two-pronged process. Today, we will be issuing a statement, and we'll make sure that we share that with everybody, that says we have a nursing home crisis going on right now, today, and we can't wait until 2021 for this benefit. And from what we can see from this benefit, it's very narrow and niche, so it's not gonna solve the nursing home crisis that we're dealing with today. So the two-part statement is, let's figure out what we can do today to expand capacity and infrastructure and maximize the role of every existing home and community-based program and streamline some of the transition issues between hospitals, nursing homes, and home. And then secondarily, let's slow this down a little bit and be more thoughtful about it so it can serve California for the long term and not just in this crisis. So these are some of the issues that we're flagging. We have a question document. There's a committee, Ellen at PACE, the PACE Center in San Diego. Ellen is heading up a work group that's already got about 5 pages of questions, and these are the nature of the questions that we are asking, and I think Marty covered them all really well. And the department did try to show today through their grid and also some case studies about who the target population might be, and they touched on some of these issues, but not nearly in the detail that we would want to see for a state plan amendment that's statewide. And we haven't yet heard much around infrastructure capacity, workforce supply, and readiness. This will hinge on availability of services in every community and an adequate supply of licensed and unlicensed health professionals that are available to work in the home. And of course, I'm glad that the Assembly member's still here. Even if we don't have a new licensure category, it's so important that there's a central role for the legislature and that there's oversight to make sure that this achieves the intended results. From the Alzheimer's Association perspective, we're concerned about hospital readmissions that may not show up. If people are sent home under this Medi-Cal benefit and then they're cycling in and out of the hospital, that would show up on the Medicare side and wouldn't, we want to make sure that that is not a good outcome. And we want to make sure that that's captured and evaluated. Next slide. So just in closing, before we take questions, a reminder that today is the second of 3 stakeholder meetings, 3 to 5. Here's the link so everyone can join. Last time I think there was only time for 1 or 2 questions. So please use the chat feature if you're on that today to put in your questions so they get captured. Also, if you haven't as an individual or organization, in addition to what we're all doing through the collaborative, you can send your public comments to this address there at the bottom. And if you are part of an organization or coalition that has specific concerns, we would urge you to reach out and request a meeting with the department to sit down with them, by phone or Zoom to address your specific concerns. And with that, I don't know how much time is left for questions, Athena.
You're right on time. We have about 10 minutes for questions. If folks have questions, it looks like you can use the Q&A feature, not the chat feature, but you can send them in the Q&A and I will read those off to folks. And if you are on the phone only, it looks like we have a few folks who are on the phone only, so you can press *9 and then I will raise your hand and then Maria or I can unmute you so you can ask your question directly. So do we have any questions? Go ahead and type them into the Q&A or raise your hand by pressing *9 on the phone. I'll just start by saying thank you. That was great. I know you guys were, working to the last minute as things, were sort of coming. And then of course, right before you get on, new information has come. So thank you for doing this in a time when everything's moving literally by the minute. So it was a really great overview of kind of where we are and where we hope for it to go. And again, great opportunity this afternoon for folks to have time to review what's come out and be part of the stakeholder process. And I think the collaborative, as this is one of our 3 policy priorities, will definitely work on getting another letter out based on our review. So thank you for that information. So we have the first comment is just thank you to everyone at the collaborative and to Assemblymember Nazarian for all of your time and work on this. And I think some of the reflections of that in the budget cuts that did not happen. So thank you for your support. The second question we have so far is about, will care coordinators be independent of the service agencies? Does anybody know if that's been clarified in the new?
I don't believe that it's been clarified yet exactly how that will work. We know historically there's a couple of issues. Of course, some folks have been concerned about conflict of interest. On the other hand, if you look at the ADHD PACE program, some of the programs that integrate services, they obviously do both care coordination and a range of services as well. So you could have two different points of view, I think, on that. But I don't believe the state has made it clear yet for this particular benefit how that might work. Susan, did you pick up something else on that?
No, I think it really depends who the licensed entity becomes. If it's a health plan, if it's a community-based agency, if it's a newly created licensure category, and whether they're on staff or contracted out, because the rate will be, there will be one rate. So care coordinators wouldn't be paid separately. They would be either employees or contracted through the licensing agency. And that's actually, that's one of the questions we have is, words matter. Is it care coordination or is it case management? You know, is it really just referrals and authorizations, or is it hands-on case management, which is a different skill set? I don't know that answer myself.
That's a good point. So another question, and sort of question / comment about, you know, the role of unpaid, you know, family members and friends that are obviously, as we all know, a big part of the support system for a lot of these folks, and how to sort of assess that capacity and make sure that whatever comes out provides some sort of training and other support for those unpaid workforce members. Do you all know if that's been part of the discussion? Yeah, it looks like.
I'll take that one. That's really important, and part of the motivation here for the department is to move very quickly. If we really are going to bypass or decompress nursing homes, this isn't something that can unfold over 2 or 3 months' time. We're talking about 2 and 3 day, you know, hospital discharge. Things happen very quickly. We're very concerned that, you know, first and foremost, the individual needs to be assessed properly to make sure he or she is able to go home. And secondarily, the caregiver needs to be assessed. And so that's an important point that we're making, that systems need to be in place, proper assessments. It can't be as simple as, do you have a caregiver at home? Check yes or no. That is not an assessment. You know, we really need to see the capacity, what the home environment is like, how the person is equipped. We know many caregivers are elderly themselves and have chronic and disabling conditions in their own right. And especially if this moves very quickly, the household may not be set up, you know, to welcome somebody home immediately. That's a very important point that we want to keep hammering on.
Totally important point. Thank you for raising it.
Great. I think we have a question on the phone from Debbie Toth. Debbie, is your line open?
I'm on the computer, but can you hear me?
There you are. Yep, we can hear you.
Here I am. So you know, and I'm sorry because I missed the beginning of this because it starts during my Friday all staff meeting. So I apologize if you covered this and I missed it. But part of our frustration is this brand new benefit being stood up when the existing infrastructure could be lifted up rather than creating something new. And I understand that creating something new in a statewide context is a good thing over a long period of time, but when people are dying, energy and effort needs to go to lifting up. And CCT has been doing this for, I mean, this is what they do. They get people out of skilled nursing facilities and move them home, and they do exactly what you were just talking about, Susan, in terms of looking at, are there caregivers in place? Is the house accessible? Is there sufficient access to food and support once they're home? Like, all of those things are already happening. And so I'm just curious how much we're able to get the Department of Healthcare Services to shift to actually looking at now and beefing up what we have in existing programs and services, whether it's CCT or MSSP or whatever. What is the energy and effort for them to pull away from making this? It just is a fire hose, right? It's 100%. They've got a ton of staff working on it and people are dying. Like, is this coming up? Is this something being addressed?
So, Debbie, you know, Marty here, I think that two things we said that I think start to speak to it, but your point is well made. Number one is, of course, the LTSS, the stakeholder group's recommendation that we do two things, one being more the crisis approach of how we deal with this issue today, and the second being a long-term discussion of an LTSS benefit, really, over time and being well considered. I think the second place that it comes up pretty regularly is most of the advocates are saying there are agencies, community agencies and home and community-based service agencies out there that can do this benefit, and let's look at that as opposed to simply using a home health model or a hospice model or a new licensed entity type of model. So those are the things that makes me think of. So I think, yes, your point is good, and yes to the point. Susan, you want to add to that? No.
I would just say that that's an excellent point to make today. If anyone gets on the phone or in the chat, to raise that issue, that very issue, is we could be spending the time right now beefing up existing programs and investing in existing programs and maximizing any of the flexibility that's afforded us by CMS in this crisis. I don't know that we've taken that to the full extent of what's available to our state.
Thank you.
Thanks. So I think we have time for one more quick question. I also just wanted to point out that Maria put the information for the stakeholder meeting in the chat, since it's hard to copy and paste from the PDF, or maybe you can't. So you can pull up that chat box and get it so that you can put it on your own calendar if you don't already have that information. So thanks for sharing that. And then I'm going to go ahead and give Randy Hicks our last question for the panel. So your line should be open.
Okay, so this has to go with the consumers. We have friends of ours who are in nursing homes now, and we do want to get them out because of what's happening with COVID. So here's my question. What's the timeline on this? How are we going to make sure that the people who are in nursing homes can get out to places and supports? I like what Debbie Toth said. She made it quite clear that there's not a lot of stuff out there now, and a lot of stuff out there is in danger from the budget. And just my second question was kind of what I wrote in the chat a little bit, is what's happening with the federal government on this and CMS? It seems like right now we don't have an administration that's not too friendly about LTSS, and he wants to cut everything from the back end, even though he gives money on the front end. So that's the question. Do we have enough information to give to consumers about how LTSS benefit works, and how do we make sure that these programs, as Debbie Toss says, who's already been doing the work, showing up the budget to make sure that this is a long-term benefit and not just a short-term thing?
You know, Randy, thanks. The only thing I would say is this crisis work that the LTSS and stakeholder group is doing is aimed to come out with something by the end of the month, if I understand properly. Now, that doesn't mean the state's going to do it, but that's our timeline, is to get a pretty quick response of things that can be done now, right? It doesn't guarantee them happening, but again, it's moving the advocacy for making those quick changes and flexibilities, you know, so I think that's, you know, one point. Your federal question is really good. I did notice that in the latest draft of the state's paper, they refer to Medicare Advantage and Medicare-related benefits and trying to coordinate with those, but I have not seen, and maybe somebody who works nationally can tell us if we're seeing any federal movement in the LTSS space that would be needed now. Susan, do you have anything on that from Alzheimer's work? No.
I don't have anything to add to that, Marty. No.
No. Okay. Thanks, Randy.
All right, so we get one more question that I'm going to sneak in here because I want to give folks the opportunity to pick your brains. So Anna Acton, you have your line open. Do you want to ask your question directly?
Oh, thank you so much. I get a question. Yeah, no, thank you all so much. So this is a really important topic and so timely, obviously. So And there's been so much great work happening around it. It just, you know, I think there are a few things. One, kind of building off of other people's comments about leveraging resources and programs that exist. You know, the CCT program is a perfect example of that. But I did want to just kind of lift up, Department of Rehab has a transition fund. And this allows us to apply for up to $4,500 in direct financial assistance for individuals for diversion or transition. And the reason I wanted to bring it up is during things like COVID, trying to kind of navigate lack of workforce for personal attendant care and to provide the housing modifications in a very timely manner. We find this fund through Department of Rehab super flexible and very timely to use. It literally will take 1 day to get approval on use of the funds. And that allows us to work very quickly and nimbly and really develop an individualized plan for people. And so I just wanted to point that out, as we need a system, especially during COVID, to have access to funds to help people transition or divert them from going into a nursing home. And that, I think, is a perfect system, an example that could be built off of to be able to get access to the resources quickly and timely and based on the individual's needs. I also just am going to say that independent living centers have a core service of transition. This was added to us a few years back and with zero funding. And so, you know, again, looking at any community providers, CCT, ILCs, AAAs, whoever, home health agencies, whoever is doing this work, they need to be leveraged, supported, and we need to increase their capacity to be able to do this work, because I think that's where we'll get that timely ability to respond during COVID.
Yeah, I think, thank you for that. And I think that feeds into, so the last comment that I'm seeing here as we wrap up this panel is just a note from Debbie that JC did say on the call that they've tried for some flexibilities in some of their 1915I state plan programs, and that flexibility isn't being given. But of course, we've seen some really good and fast flexibilities happening in the CCT program and CBAS and MSSP. So that again points things like independent living centers where, you know, let's leverage what we've got and build on the ability to make those things flexible and help with the immediate need, which is, of course, goes back to Susan's discussion early on about this two-pronged approach of let's deal with the immediate need and then think more long-term about the system change. So thank you for this. Marty, it looks like you have something to add. I'll let you.
Yeah, totally briefly. I saw a question go by about the lack of housing and homelessness, and I just thought it was worth acknowledging that that's one of the questions that we've been asking as well. Obviously, a state that has a great shortage of housing and a big homeless population, very hard to move people into new housing. And so far, unless it's in today's version, we don't see a response to that issue. An important issue as well.
Thanks, Marty. I appreciate that. That's a really good point. Something that's always on the horizon there, some sort of sustainable supportive housing solution as well. So, well, thank you again to both of you for your time. We know you're running from meeting to meeting and giving us up-to-the-minute updates. And thanks to everyone for all of your great questions and comments. Much more to come on this. The collaborative will be better equipped to see how we can help influence the policy. So we're going to skip in the agenda and jump to, thank you, bye Susan, jump to the creation of a Health and LTSS Advisory Council, and then we will go back and hear a little bit about the long-term care financing proposal. So one of the other priorities that came up as we went out to ballot with the collaborative last week was looking at taking the concept that was developed in our last round of policy priorities, which were of course part of a pre-COVID discussion, and looking at the transition of the CalMedi Connect program and some sort of statewide dual eligible special needs plans and statewide MLTSS program, and having that be sort of monitored and developed in conjunction with a advisory council. And often Massachusetts is used as an example for when they developed their financial alignment demonstration and how they really did bring all the stakeholders together and put them on an advisory council that really was more than just checking a box that they hit some stakeholders. It was really utilizing the expertise and the various perspectives of a advisory council to think through some of the policy and operational issues as the policy and program design was developed. And so as things have sort of shifted and we're looking at things like a long-term care at home benefit and CalAIM and some of these bigger things that are being proposed, which would have implications for LTSS statewide, the thought was that this was sort of running theme through all of the comments, that for all of these different proposals that became priorities, there really is a need to think about how we could have some sort of a state, mandated and run advisory council that would serve that purpose here in California. So we sort of took the idea from previous policy priority and kind of expanded it to say, well, we don't want to create, 8 different advisory councils, so let's think through how that goes. I think we have some work to do on sort of defining how that looks. And working through, looking at obviously the Master Plan for Aging LTSS subcommittee, and we just heard from some of the wonderful participants on that. What role does that have? Does that go away when the master plan is released, or is there some thought that would continue? And so you would take that and maybe build on that. There's other, things going on like the Alzheimer's committee, which I know has been working with the Master Plan committee. Department of Healthcare Services has their stakeholder advisory committee process. I've got the Commission on Aging, the Olmstead Committee. So of course, thinking through how this looks and how it would be different or how it would build upon some of those existing stakeholder resources and how we could really work collaboratively with legislators and departments and agency and other stakeholders to really think through how to make that the most effective body that it could be. So we're going to have to put a little bit more thought into this. We wanted to just kind of think through with the group, sort of this is the initial stages of thinking through what that would look like and how the collaborative could have a pretty big role in that, while still separately maintaining the collaborative's role as an advocacy organization that's outside of this planning council, which would be, run with the state's blessing, so to speak. So I will stop there and see if folks have any thoughts or questions. And again, you can use the Q&A feature or raise your hand and we will unmute you. Okay, well, like I said, somebody has their hand raised. Randy, did you want to say something, or is that from before?
Yeah, the question is, what is the timeline on the advisory council? What are your your goals, your mindset, what you have with this advisory council, and what is your end game? I mean, we've had advisory councils. I've been on a couple of advisory councils myself. Reports end up sitting on shelves somewhere. And what's the end game with this advisory council? And is it going to be for more money? Is it going to be for more services? Is it going to be working with conjunction with what you guys just talked about in the last part of this meeting or the first part of this meeting? That's just kind of general overall question. What you guys are doing with it?
Yeah, I mean, I think that there's a lot more, refining to happen and discussions with other, stakeholders and leaders in the government to sort of think through how that goes. I mean, I think as envisioned, it would be a, something sort of state-run similar to the Master Plan for Aging work group, right? Where there's some buy-in from leadership, they're involved and engaged. It's not just like when they come to the collaborative and check off like, oh, we talked to the, we got the input. So it's just a check off box to make sure it's more than that. The issues that would cover, I think would be broad and wide ranging, right? It would include the long-term care at home benefit. It would include, issues around the Master Plan for Aging. It would include CCI transitions, all of the, statewide MLTSS transition that's envisioned in CalAIM several years out. So that it would really be an advisory committee, and it would include folks from the collaborative, but it would also include, providers and plans and academics and other folks that aren't necessarily part of just the collaborative, so that there would really be a broad-based discussion and input process before policies. I think the point is not so much the specifics of what we would advocate for, because this world's changing so quickly, but the idea that there would be an upfront process and that this council would serve as that purpose. So lots of details to be worked out, and happy to get input from
Anybody?
collaborative members on how they want to see that, and we will of course refine it as we move forward. So all
Good to go.
right, thank you very much. It looks like maybe we've got recommendation from, so Lydia wanted to share a recommendation from the LTSS subcommittee report, which sort of summarizes this kind of idea, right? Put in place a dedicated cross-department unit in California that is focused on LTSS, that would be led by agency and work with its 22 departments to align across. And I think that's exactly the sort of thing that we're hoping to do. So thank you, Lydia, that's important. And then let's see, Debbie had a comment about the Shattered System report that came out of the former Senate Long-Term Care Committee, had a ton of recommendations, and one was creating a similar oversight body that the administration did not buy into because of all these other committees. So yes, I think we have some refining to do about how we're gonna, maybe repurpose some of those, or suggest they rethink how some of those could all work together, because we do understand that creating just another committee that's just gonna put, not have the influence that we're really looking for up front. And so we will go from there. So thank you for all that feedback. We definitely have a little bit of a hill to climb here, but we will work with all of you and appreciate all of your thoughtful input on how we can work with other folks to develop something that would be more proactive in its input before these programs and benefit designs are established. So with that, I think I'm going to pass it off to Christina Bass-Hamilton to give an update on the long-term care financing efforts and where we are, and we'll wrap up from there. So Christina, you're on.
Hi everyone, good morning. I don't want to rehash what we all already know, but I'll do the 5-second recap. So last year in 2019, the California Aging and Disability Alliance, a coalition of groups working on the LTSS financing issue, had secured $1 million in the budget to finance an actuarial analysis of what a universal LTSS benefit or a social insurance program type benefit would look like in the state of California. And to be clear, we're talking about a benefit for all, regardless of income level and age. Meaning that was the task of the analysis, was to look at the cost across the board, and it was going to look at different scenarios of eligibility also. So in hindsight, boy, am I glad we got that money in 2019, because that wouldn't have happened this year. So Milliman Group was contracted by the state to do the analysis. Statutorily, the report was due on July 1st of 2020. We have confirmed that the analysis was concluded by Milliman, has been submitted to the state, and it is under review. Richard Figueroa confirmed to me yesterday that they are reviewing the findings and have not yet, or are not yet making it available to stakeholders. So there's not much on the findings that we have at this point, but I think where we are currently, and I spent some time really thinking about this yesterday, is in the COVID environment, what does COVID mean for the work of the LTSS, social insurance program, universal LTSS / long-term care financing reform? I'm using all of those terms because people use those terms interchangeably on that. So in my mind, I keep going to the state and the legislature and the governor have very few priorities at this moment in time. At least this is what has been said ad nauseum to stakeholders. If it's not relating to COVID, if it's not relating to homelessness, if it's not relating to wildfires, there's very limited appetite to take things on at this moment. I believe that there is a connection to COVID. There is a very strong connection that we had already been making on the homelessness issue and on poverty in general. So I'm inclined to think that moving forward, the way to approach the LTSS financing / proposal on a social insurance program is to really go to the heart of this as a means to address poverty and specifically the spend down of middle class families into poverty in order to access services. So I'm throwing that out there simply because we've been on unclear footing since March in terms of what is the next steps, and frankly, without getting the actuarial findings, we can't really do anything. But then moving forward from there, how do we generate interest in the legislature? How do we win ultimately a new benefit? I'm increasingly thinking that we have to be very, very clear that this is an anti-poverty measure. So those are simply my thoughts. None of this is set in stone. I'm just sharing what I've been thinking about. But aside from that, there's not anything tangible I can report to you all. Aside from that.
Great, thanks, Christina. Just kind of a good update. We know you've been, along with many others, working hard on this for a long time, and hopefully we will see that report soon. So we have just a minute or two if anybody has any questions for Christina. Go ahead and raise your hand, or otherwise we will look forward to more updates. I know you guys are watching that closely, and we really appreciate all the hard work, and we will continue to reach out to make sure the collaborative is helpful as we get more information from the actuarial study and what that means for how the lawmakers and the department will look at that going forward. So thank you again, and I think that wraps us up here. And so thank you everybody for participating. We know you're all busy, and have a great weekend, and we will be back next month. And if for collaborative members, look for some emails as we move these policy priorities forward and further refine them. So, thanks everybody.